I'm Michael Atkins. I'm a medical oncologist, and my principal interests are in treatment of patients with melanoma, kidney cancer, and a new type of research called immunotherapy research. I'm also Deputy Director of the Georgetown Lombardi Comprehensive Cancer Center. The patients that I see are patients who either have advanced melanoma that has spread to distant parts of the body, or have had melanomas resected from their skin that have high-risk features that put them at risk for developing advanced melanoma. My patients with kidney cancer are primarily patients who are sent by urologists or other medical oncologists who've had high-risk masses in their kidney removed and are at risk for spread to having the tumor spread to distant parts of the body, or who have already had their cancer spread to distant parts of the body and are seeking expert or novel types of treatments for their disease. These are complicated, life-threatening cancers, and there are now very good treatments for these cancers that didn't exist before, and that most general oncologists may not have the level of experience with. In addition, the treatment of cancer, in order to get the best results, requires coordination of care between physicians from multiple different specialties. It has been unbelievable to go from a situation where we had very little to offer, where now we have an embarrassment of riches, but it still requires judgment and understanding and experience to know what treatments to give to particular patients first. And you can only get that at an academic medical center where there's expertise in managing a specific disease and where they have access to tomorrow's treatments today as part of research protocols. It's so great to be an oncologist where we actually have treatments that can make patients' disease go away. These are patients who come in and they're desperate and they're very afraid, and we can fix their problem, not just now, but forevermore. And when we come up with new therapies for diseases, it doesn't just help one patient, it helps all patients who come down with that disease from now till eternity. And so that's the great potential of both treating patients and doing research to develop new treatments for patients with cancer. And that's what academic medicine is about, and that's what oncology is about. So it's a privilege to be part of that process. So melanoma is a cancer that forms in the skin, develops in cells which are called melanocytes, which are the cells that form the pigment in the skin. And when they're exposed to sun, UV light, or for hereditary reasons, develop mutations that allow the melanocytes to grow in an unregulated fashion, which turns into melanoma. So a number of patients are always asking when they're diagnosed with a melanoma, why did this happen to me? I've been healthy my whole life. And there are a lot of risk factors that are associated with melanoma. The principal one that I think people hear about, and is the one that's modifiable, is the sunburn, particularly sunburns before the age of 20. If you have multiple sunburns before the age of 20, you increase your risk of getting melanoma, but even sunburns later on in life can increase the chance of a melanoma developing. And so that counts for about a third of melanomas. A third of melanomas are related to genetics. People who have fair skin, freckles, blue eyes, red hair are more likely to get melanomas. Those are the people who burn rather than tan. But there are also people who have a lot of moles who have familial characteristics of those moles that make them more likely to turn into melanoma. And then about a third of people we don't fully understand, but it's probably a combination of sun exposure, genetics, and other factors that are subject of research. Melanoma is distinguished from the other more common skin cancers, basal cell cancer and squamous cell cancer, in that it has a very high propensity, even when it's small, to get into lymphatics or blood vessels and spread to distant parts of the body. So the risk of melanoma spreading to distant parts of the body is related to several factors. One is how thick it is, with melanomas under 1 millimeter being considered thin, over 4 millimeters in thickness being considered thick, and the 1 to 4 being intermediate. Second most important risk factor is loss of the surface layer on top of the tumor, which is a biologic property that we call ulceration, which is associated with an increased ability of the tumor to get into a lymphatic or a blood vessel and spread to distant parts of the body. The third is how fast the tumor is dividing, what we call mitotic rate, since divisions are called mitoses, and we can see that looking at the tumor under the microscope. And the higher that is, the greater the risk. And the fourth, which is a procedure we actually have to do in patients who have some of the other risk factors, is whether or not the melanoma has gotten into the lymph node that drains the patch of skin where the primary is. And so that's determined with a procedure called a sentinel lymph node biopsy, where some radioactive tracer is injected around where the melanoma was, and it travels to the lymph node that drains that patch of skin. And a surgeon can take that lymph node out and hand it to a pathologist, who can now look at it very carefully to see whether any melanoma cells have gotten into the lymph node. And all of those factors combined together tell us what the stage of the tumor is, and each stage is associated with a certain risk of recurrence, all the way from essentially 0 if none of those risk factors are there, to as high as 80% if most of those risk factors are there. So it's very important before we develop a treatment strategy that we know the stage and what the risk of recurrence is. Many patients ask me, when I talk about recurrence, will it be just another spot on the skin like this lesion? And although that can happen, and people who have had one melanoma on their skin are at risk for getting a second melanoma on their skin. But when a medical oncologist is talking about recurrence, we're talking about this melanoma, the one that the patient has, having spread to lymphatics or distant sites into the lungs or the liver or the brain, which is associated with a high risk of mortality in the past, although fortunately we now have treatments that we could potentially offer patients that can even make the disease go away once it's spread. Many people think that because the sentinel lymph node biopsy doesn't show melanoma, or a chest X-ray or CT scan or even PET-CT scan is free of melanoma, that there's no disease in their body. They have a hard time understanding that these tests are not 100% sensitive. In order to see a lung nodule of melanoma, there need to be 1 billion cells in one place. And it only takes one cell to spread to the lung to grow eventually to 1 billion cells. So if we don't see anything on a PET-CT scan, or we don't see anything in the sentinel lymph node biopsy, it doesn't mean that the tumor's gone. It just means that we can't see it at present, and that there's a lower risk that the tumor may actually recur. But there's still a risk of recurrence, and that's what the staging actually gives us. So because we have now treatments that are very good for melanoma if it recurs, it's very important to identify a recurrence early so that we can maximize the utility of the treatments we have to offer. So what we're usually recommending to patients who have intermediate or high-risk primary melanomas is that they have regular follow-up with a medical oncologist, and that follow-up usually consists of a history, careful physical exam, identifying symptoms or physical findings that might be associated with risk of melanoma recurrence, some very simple blood tests that might clue us into a patient who's at an increased risk of melanoma recurrence, and at least a chest x-ray, and for higher risk patients, CAT scans or even PET CT scans to identify disease recurrence at the earliest possible actionable time so that we can actually begin to develop a treatment plan for them. What is important is that you have regular follow-up with a medical oncologist who will ask appropriate questions and do appropriate exam and do appropriate lab tests and imaging to identify the recurrence. Occasionally, patients who are at high risk can take treatments that might lower their risk, either standard treatments or participate in clinical trials of what will be potentially the treatments of the future to try to lower their risk. And it's very important that they can stay in communication with their doctor so if they identify a new symptom or a new physical finding that they don't wait for their next appointment to have it evaluated. Well, melanoma has always been thought of as a cancer that's uniquely sensitive to the immune system. And so the immune therapies that were developed for cancer were mostly developed in patients with melanoma. And some of them, which I participated in developing, such as high-dose interleukin-2, produced treatment responses in about a quarter of patients and cures in 5 to 10% of patients, which we viewed as a proof of principle that if we could identify why the treatments worked in some patients and not in others, that we could develop better therapies. And over the past decade, through research, we've identified why the treatments work in some patients and not in others, and we've identified a series of breaks on the immune system that the body has that shuts the immune system off when it becomes activated and tries to kill the tumor. And we have developed, with our pharmaceutical colleagues, antibodies against those checkpoints, those breaks that take the brakes off and allow the immune system to be unleashed against the cancer. So these are drugs called ipilimumab, which is what's called a CTLA-4 antibody, and drugs that target the anti-PD-1 pathway. And each of those has been a stepwise improvement over the previous therapies, with ipilimumab producing long-term survival in about 20 to 25% of patients, the anti-PD-1 agents producing a long-term survival in as much as 30% of patients. And the recent things that we've been working on are combining the anti-CTLA-4 blocking agents with the anti-PD-1 blocking agents, where we're now seeing 50% of patients having their disease go away and about 65% of patients having their disease controlled, and it looks like as many as 60 to 70% of patients may have long-term survival with those therapies. But melanoma has another advantage, because while we were advancing our understanding of the immunobiology of melanoma, we've also done some research to advance our understanding of the molecular biology of the tumor, and it turns out that about half the tumors are driven by a pathway called the BRAF pathway and contain a mutation in the BRAF gene that allows the protein to always be on. And so we've been able to develop selective inhibitors of that pathway that block melanoma growth in the tumors that have that mutation reliably in 75 to 80% of patients, and can produce dramatic responses even in patients who are near death, almost a Lazarus effect, where they'll be better in a week or two and can go back to leading a normal life just taking pills for months to years. The trouble with that approach, as compared to the immunotherapy approach, is eventually the tumor figures out how to get around that block. And you need to then come up with an understanding of what that mechanism of resistance is and block that new escape pathway. We've identified what that mechanism of resistance will be for the majority of patients who are getting a BRAF inhibitor, and that's a downstream activation of another pathway called the MEK pathway. And when we add a MEK inhibitor to a BRAF inhibitor, it doubles the benefit of the BRAF inhibitor. But eventually, patients' tumors will develop resistance to that approach as well. So we need more research to figure out what the escape mechanisms will be for the combination, what happens to how we treat patients who don't have those mutations in those tumors, and how we integrate this molecularly targeted approach with the immunotherapy approaches. If you look in a textbook, there are the A, B, C, Ds of melanoma, changes in the mole that make it asymmetric, changes in the border of the lesion that makes it irregular, variegation in the color of the lesion or a diameter that's greater than 6 millimeters. And those are the classic characteristics of melanoma. But what people don't understand is that a lot of melanomas don't have those characteristics. And so we've added to the A, B, C, Ds an E, which is evolving. And any mole that changes, whether it's pigmented or lacking pigment, whether it has an irregular border or just becoming raised, is something that we're worried about, and somebody should, if they notice a mole that's changing, they should see a dermatologist. If a mole is changing, you should go see a dermatologist, and the dermatologist, if it has characteristics of a melanoma, even if it doesn't have the classic characteristics, should be sophisticated enough to identify when it's worrisome and biopsy it so that it can be sent to the pathologist for analysis. And sometimes you can't tell. Even the most experienced dermatologists think something is benign, but something wrong with it encourages them to do a biopsy and send it to the pathologist, and is surprised when it turns out to be a melanoma. Metastatic melanoma is melanoma that's spread to distant parts of the body, either to a distant lymph node, a different area of the skin, or more likely to the lungs, liver, brain, adrenal gland. And melanoma is characteristic, one of its major characteristics is even when it's small, just a few millimeters, it has a risk of getting into the bloodstream and spreading to distant areas. And these tumors are very aggressive, and they can grow in all different parts of the body where many other cancers can't grow. So we can see metastases in practically any organ. It's still called melanoma. It still needs to be treated as melanoma. And that's why it needs to be followed by someone who understands the biology and the behavior of melanoma to pick up these recurrences as early as possible. About 5% of people with melanoma don't have a skin lesion. Sometimes melanoma can develop in mucosal surfaces, such as in the nasopharynx, or in the vaginal mucosa or the anal rectal mucosa. Sometimes melanoma could have started on the skin but have been eradicated by the immune system, but cells may have gotten beyond the skin to distant sites, and people present with those distant sites when there's no evidence of a primary tumor. And so you don't have to have had a mole to develop melanoma. And once it's diagnosed as having melanoma, it gets treated in a similar fashion, though. So if you read in the textbooks or on the internet, which tend to be out of date, they'll say phrases like melanoma is a bad disease and it's not curable once it's spread to distant sites. But that is not the case. Melanoma is now one of the most curable of solid cancers because we have great treatment options, and those are improving every day. And we now think that as much as 50% of patients who have distant melanoma may be cured by our new treatment approaches. And these approaches are being refined all the time through our research studies, and we hope that those results will even be better in the years to come. So the treatment for a patient with stage 4 melanoma depends on several factors. Where the disease has spread to, so it requires staging to see all the sites of where the disease has spread to, including a brain MRI to see whether it's spread to the brain, and if it's CT scans or PET CT scans to see where else it's spread to. The molecular biology of the tumor, whether it contains a BRAF mutation or potentially other mutations that might be targetable, and the age and other illnesses that the patient has. For most patients, no matter what the molecular stage is, if they are in good shape and don't have a lot of symptoms from their disease and don't have a lot of other medical conditions, we will choose an immunotherapy approach as the first treatment because it's the approach that can produce durable off-treatment responses, responses that persist after the treatment is stopped, what we call cures. For many patients, however, if they have a BRAF mutation and they have symptoms of their disease, we would recommend trying to get immediate control of their disease by giving pills that target the BRAF pathway that quickly slow down the progression of the disease and allow the patient to feel better. And then we need to figure out when the optimal time to switch from that treatment to an immune therapy is. For patients who have disease that's spread to the brain, we typically want to treat the brain first with some specific radiation therapies like CyberKnife treatment that we have available here at Georgetown University Hospital to control the disease in the brain, which may be less sensitive to our systemic therapies before we start the systemic treatments. So the treatments that we now use are not chemotherapy. They don't cause hair loss, they don't cause nausea and vomiting, they don't cause low blood counts that put patients at risk for infection or bleeding. The way cancer is being treated in the melanoma clinics is not the way people think about cancer being treated. The pills that we give that target the BRAF pathway have very little side effects. Some of them are skin rash. Occasionally patients develop a fever, and occasionally patients will develop joint aches and pains. The immune therapies that we give have side effects that affect maybe about a third of patients, while most patients have no side effects whatsoever. And the side effects that people get are activation of the immune system against normal structures. So you may see activation of the immune system against the skin, which leads to a rash, which we call dermatitis, or activation of the immune system against the lining of the colon, which we call colitis, or activation of the immune system against the liver, which we call hepatitis, or against various endocrine glands, such as the thyroid gland, what we call thyroiditis, or the adrenal gland, adrenalitis, or the pituitary gland. And these are mechanism-based toxicities because we've activated the immune system, and sometimes some of these ways of activating the immune system are not selective enough for just the tumor, but we activate the immune system against normal structures. And we can treat those toxicities with immunosuppressive agents that suppress those toxicities, but it's interesting that they don't seem to interfere with the activation of the immune systems against the tumor and the immune system's ability to eliminate the tumor. So when we see these things, we know we've done our job with the drugs, and it's probably when we have to stop the drugs, but we know that if the immune system's going to seek out and destroy the tumor, we've activated enough to do it. A lot of the treatments which are now approved treatments, the BRAF inhibitors, the MEK inhibitors, and the anti-CTLA-4 or anti-PD-1 therapies have been approved for patients with melanoma, but sometimes only in restricted settings. And we still need to do research to be able to give drugs in combination, to give drugs in the first-line setting as our first treatment for patients with melanoma, to give some of these drugs to patients who are at high risk for recurrence rather than have already recurred, and to give it to patients who have unusual presentations of their melanoma, such as disease in their brain. And those are all research studies that we're currently doing. In addition, there are new drugs that work as well, if not better than these drugs that we're studying, and we're trying to combine those approaches with the existing approaches, and that's only available through research studies. When drugs are provided as part of research studies, they're provided free. So they don't have to, patient doesn't have to pay, the insurance doesn't have to pay. It's the pharmaceutical company or the National Cancer Institute that's providing the drugs free for the patients. And some of these drugs, if they were billed to insurance, might be hundreds and thousands of dollars worth of expenses, but it's just provided free. So why should someone who has melanoma come to an academic medical center like MedStar Georgetown University Hospital, or in particular MedStar Georgetown University Hospital? It's because we have the latest treatments for patients with high risk or advanced melanoma that are showing better outcomes than prior therapies. And we have teams of physicians that are working together to deal with all the different presentations of melanoma and all the potential consequences of these new therapies in order to make sure that each patient gets the best outcome possible for their disease. And if you start your treatment in the wrong direction, it may not be possible to get back to the right direction. They teach us in the textbooks how to do things right, and as we write the textbooks, we're constantly changing that, but they don't teach us how to get from the place that's wrong back to the right place. And so it's very important that before the treatment starts, that a plan is in place that maximizes your ability to get the best benefit that you want from whatever therapy is being offered. So with regard to treatment of melanoma, it requires the interaction of a medical oncologist with a surgical oncologist, with a dermatologist, with specific dermatopathologists and radiologists in order to get the best management for the primary melanoma. And for patients with distant spread of melanoma, it requires a team of physicians who have access to the latest therapies and understand in which order to use them. So it's not just a treatment, but a treatment plan that patients need in order to get the best outcome for their disease. research plays a very important part in oncology management. The treatments that we now have available for patients with advanced melanoma did not exist 5 years ago, and they've been developed through research studies over the past 5 years. And the patients who participated in those research studies had a chance to get access to these treatments that are now the standard of care well in advance of their actual approval. And because some of these treatments are major advances over the prior therapies that we had available, the patients have had their course of their disease influenced dramatically, and some of these treatments are now potentially curative. And so we've gone from a situation 5 years ago where at most 5% of patients with stage 4 melanoma could be cured of their disease to where we now anticipate that as many as 50% or possibly more can be cured of their disease with these new treatments. But we don't want to stop there. We want to be in a position where we can cure everybody of their disease, and that requires more research to figure out how to better use the treatments we have, in what orders to give them, who to give them to, and what to do with the patients who aren't going to respond to those treatments, so that we can make the treatments better and develop new treatments for those who are resistant to this, what have become the standard therapies.